Our final presentation today is going to be from Dr. Rizwan Sardar. He's also an interventional cardiologist at Memorial Medical Center in Las Cruces. Dr. Sardar is an experienced medical director with a demonstrated history of working in the hospital and healthcare industry. He specializes in interventional cardiology, structural heart disease, peripheral vascular disease, and vascular heart disease. Dr. Sardar is a board certified in internal medicine, cardiovascular disease, and interventional cardiology, as well as nuclear cardiology and adult echocardiography. His interests include TARV, Watchman, Myrdal clips, Impella, coronary PCIs, and much more. So please help me welcome Dr. Sardar. Dr. Sardar, I'm going to pull up your slide. Just give me a quick second.
Thank you. I can share my screen. Thank you very much.
Let me make sure you're co-host.
Mm-hmm. Can I share my screen because I made some changes to the slide since the last time I sent?
Okay.
You're good to go, Dr. Sardar.
You just want to share your slide, share your screen.
Just continue. I'm sorry about that.
Do you want me to share my screen?
Yeah, if you can
okay.
Share. Yeah, thank you.
Okay.
Thank you. Good afternoon, everyone. I'm one of the heart doctor, interventional cardiologist, and my specialty is interventional cardiology, especially focusing on structural heart disease. Next slide. These are my disclosure. Next slides. The objective that I kept for this talk is very simple. This is basically to discuss about common causes of cardiovascular origin of stroke. Stroke is a broad topic, but I would like just to focus on maybe a couple causes or maybe 3 causes which are most often encountered, and people have a lot of question about it. What kind of population is at risk and how much is a burden, what is the epidemiology, and what are the treatment strategies. So we will try to cover in this whole presentation, and hopefully I will be done in 45 minutes and take some questions. Next slides. As a provider, whether they are a doctor, nurses, or anything, and most of the time I see the room full of raised hands, for atrial fibrillation. But atrial fibrillation is an epidemic, and most often people who claim, people who ask me about what atrial fibrillation is in a layman term is irregular heartbeat. The biggest problem with atrial fibrillation is that as our population is aging, its incidence is increasing, and it's almost to the level of epidemic right now that more than 33 million, and it's an old slide from 2014, patients have atrial fibrillation on annual basis. As you grow older and you have more comorbidities, your risk of stroke is exponentially high with atrial fibrillation. One thing we have known from old cardiovascular studies that most of the patients with atrial fibrillation, they have a clot which comes from the heart. And that is why it is the most common cause of can you go next slide? Whenever we have atrial fibrillation, our goal is, number one is medicine. Medicine to control the heart rate, but at the same time, it is also to make sure that we give medicine to keep the people in normal rhythm as long as possible. The second component of medicine is to give blood thinners. And we have traditional medications like warfarin, which is a blood thinner which has been tested and has been around since 1980s. In most common word, it is also being called as Coumadin. And I basically sometimes tell the patient that it is actually a rat poison. That's how this drug was actually apixaban, rivaroxaban. And last but not the least, now we have some methods which are basically interventional, and we will discuss about those kind of procedures. Next slide, please.
And Dr. Sardar, I'm sorry to interrupt. We're just, it goes good and then it cuts off. So I'm not sure if it's your connection or if it's just maybe the room you're in. So I wanted just to let you know,
Okay.
if it continues to cut out, I'll let you know in the chat. So if you want to continue for now, we'll try one more time.
But they all come with their own kind of problem and the risk factors, especially the one which is called warfarin. It has a bleeding risk. It has tendency to go with daily regimen issues, and a lot of patients are not able to basically adhere to warfarin just because of the fact it has many interaction with foods and the drugs. Next slide. The same issue is actually with newer oral blood thinner as well, like dabigatran, like rivaroxaban. They are very good because you don't have to check the INR, but at the same time, they also have issues. There is a traditional method of stroke prevention that is, I can try to log in from my desktop. If
Yeah,
you
do we want to we'll pause for right now and then
Sure.
and I'll, okay. So I'll keep it on this slide, and if you want to just, yes, we can hear you.
All right. Just wanted to check everybody can hear me.
Yes, we can. Go ahead.
Okay, thank you. So in terms of the medication that we have available, the most common medication is warfarin, and the newer medication all have their own type of benefits and the risk profile, especially considering about the warfarin. It has a risk profile of changing the regimen depending upon what kind of food you are eating. You're eating more vegetables, you are eating, and especially also about the interaction with the drugs. The newer oral anticoagulant agents are also very good, but they also have their own subset of problem. Especially they don't have a reversal agent available, and you have to have complication during the surgical procedure because of lack of availability of a reversal agent. There are several methods that we quantify the risk of stroke in patients, and the most traditional method that has been used is called CHADS-2 score. CHADS-2 score is a composite of heart failure, hypertension, age, diabetes, and the more the numbers that you have, your risk of stroke actually exponentially increase. Next slide. The current guidelines for atrial fibrillation tells us that at this present time, that any patient who has non-valvular atrial fibrillation, they should be on blood thinner, which could be warfarin, dabigatran, rivaroxaban, apixaban, and doxaban. There is category 2A in the patients who basically have atrial fibrillation, but they have moderate to severe mitral stenosis. It is a choice of a physician if they want to continue. Last but not the least is that the patient who have mechanical heart valves, they or rheumatic mitral stenosis, they should not be part of these kind of guidelines. So people ask me that, doctor, what is non-valvular atrial fibrillation? The short answer for this is that patients who have rheumatic mitral stenosis or mechanical mitral valve, these are the patients who are valvular atrial fibrillation, and these are not the patient that I'm talking about today. These are non-valvular atrial fibrillation. Next slide, please. As we said, that newer oral anticoagulant agents are very good. You don't have to monitor the INR, but multiple studies have shown that despite they are very good, the discontinuation of drug is close to about 30%, no matter what kind of drug you are using, including the warfarin, which is about 17 to 28%. Next slide. There is an unmet need for those kind of patients who are not a candidate of oral blood thinner, and that is one thing which we are going to discuss, which is left atrial appendage occluders. Next slide. As we said, as high your CHA2DS2-VASc score is, this is the data from NCDR Pinnacle Registry, which actually showed that even your CHA2DS2 score is high, you should be a candidate of anticoagulation. But in the real world, the anticoagulation usage is actually not more than 60%. Next slide. This is just because of what I discussed before. It is not easy to continue warfarin as well as a blood thinner because of their own challenges, and it leads to non-adherence of these medications. And this is as per the data that was collected by online survey, that 83% of patients with atrial fibrillation who are candidate of blood thinner, they have tried to seek an option of any other treatment to reduce stroke for atrial fibrillation. Next slide. This is pretty much what I said before, that the same data that is discussed before, that patients who have atrial fibrillation, the discontinuation of oral anticoagulation is close to 30%, even with the medications like DOACs. So we have great medication, but there's a lot of discontinuation of these medications because of multiple reasons. Patients are falling, patients are bleeding, or they are not good candidate because they have intracranial hemorrhage. Next slide. Left atrial appendage closure is not new. Next slide, please. Left atrial appendage closure is not new. This has been tried and tested in multiple, ways and methods. The first method that has been tried mostly in the older literature is actually surgical excision. Like if a person is actually going for bypass surgery or for any kind of heart surgery, surgeons used to ligate it or excise it or suture it or staple it. But the studies have shown that even despite surgeons are excising it, the full excision of this appendage is not completely possible. Next slide. And surgical procedure is often not fun, so we need less invasive procedures. And these are the devices that are available at this present time. Out of these devices that are mentioned here, the Watchman device is the device which has currently been approved, along with Amulet device, which is up here. These are all percutaneous ways of surgical ligation, or the percutaneous ways of left atrial appendage ligation and preventing stroke. Next slide, please. FDA approved Watchman device in 2014. Next slide, please. And this device appears like an inverted umbrella. It has a 160 micron membrane, which basically seals off the left atrial appendage completely. It's made up of nitinol, which is a conforming metal. I basically tell the patient in this way that this takes the shape of the heart and try to conform with it. Next slide, please. And it leads to the warfarin cessation rate by the 12 months greater than 99%, which is really remarkable. This was the first time that a device has shown that if you place a device in any individual who are not a candidate of blood thinner for some reason, you can actually come off blood thinner more than 99% of chance after 12 months or 1 year. Next slide, please. This is how the Watchman is being done. Is usually an elective procedure. It is usually done under general anesthesia. Now we have new techniques to do it, but mostly under general anesthesia, going from the groin by looking at the left atrial appendage anatomy by the transesophageal echocardiogram, and most of the patient goes home next day. Next slide, please. Left atrial appendage comes in different shapes and size, and it is important to measure it by transesophageal echocardiogram to understand their anatomy. Next slide, please. We size the left atrial appendage by the transesophageal echocardiogram. It comes in 5 standard sizes, and they have to adjust and conform what we get the data from transesophageal echocardiogram. Next slide, please. After Watchman is being placed, I always show this slide to the patient because they asked that, what happens to me when you place a device. I basically give an example and an analogy that if I scratch my skin and I form a scab afterward, in the same way, this is a canine model of a Watchman implantation on the left side of the screen, and this is a human pathology specimen at 9 months. It basically shows that after placement, there is an endothelialization or a new skin is forming over the Watchman. It basically completely seals off, almost like you're putting a drywall in front of a door or something to completely seal off that. That is a mechanism by how you can actually come off a warfarin or any blood thinner, and you just have to take baby aspirin for your life. Next slide, please. This is a rational thinking of deciding which patient is good for left atrial appendage occluder. I basically decided in this way that a patient who has CHA2DS2-VASc score of greater than 2 in men and greater than 3 in women, if they are suitable candidate of blood thinner like warfarin or warfarin itself, and they want to seek a rational of non-pharmacological approaches of warfarin, left atrial appendage occluder can be a choice for their stroke prevention for non-valvular atrial fibrillation. Now, how do we decide about which patient is actually best for these kind of procedure? This is, I basically call it as a common sense rule. If you have patients who have atrial fibrillation, you know that they are increased risk of stroke, but they're coming in your clinic and they're falling around, they are not steady on their feet, they had previous fall, they bled before, or you them yourself knows that they are in a high risk profession and they are not a good candidate of continuing these blood thinners on the long run. These are the people that you can make a rationale for having a non-pharmacological method of stroke prevention, provided they have non-valvular atrial fibrillation like we discussed before. Next slide, please. Left atrial appendage occluder, especially talking about Watchman, has a great data. The data is spanned from 2002 to all the way up. Even right now, we are collecting data. So I can say that this device, which is approved along with the Amulet device, has the most data behind it. And this data is spans of thousands and thousands of patients. So it has a lot of safety data. Next slide, please. Right now, at this present time, what we know about older generation of warfarin, older generation of Watchman, it demonstrates that it has a 95% implant success rate, 1.5% major procedure complication, and by 1 year, more than 99% patients are free of taking warfarin. More than 92% are free of taking warfarin in 45 days, which is remarkable for a device. Next slide, please. The data shows that patients who have undergone left atrial appendage occluder by meta-analysis, there is definitely decreased risk of hemorrhagic stroke. There is definitely decreased risk of bleeding because you're not taking a blood thinner. But all these components actually add up to not only having a lower disabling stroke, but at the same time, overall, less death and major bleeding, which is non-procedural bleeding. Next slide, please. This is multiple trials which have been computed, and it has shown that warfarin, the Watchman device is actually comparable to warfarin in providing the reduction of ischemic stroke risk period. Next slide. And disabling strokes are lower in terms of overall disabling stroke. This includes ischemic stroke, include hemorrhagic stroke in the left atrial appendage occluder, which actually is very important for our patients, especially considering it is non-inferior in providing a reduction of ischemic stroke compared to blood thinner like warfarin. Next slide, please. As we know that there is a risk to estimate who is going to have a more stroke, there is also a risk scoring mechanism which is in place that which kind of patient is going to have more bleeding when they are on a blood thinner. That risk score is called Has bled score. The important thing to understand that more points that you have on the Has bled score, of course, you're going to bleed more, but this is actually compounded on annual basis. Next slide, please. This is what I said before, that if you have a score of 4 of has bled, this means that your annual risk is about close to 8 to 9%. But if you live like about 10 years, this risk is not 8 to 9%. This is going to be compounded over the life that you're living. So we always have to make a decision based on what is a compounded risk of bleeding as they live longer. Next slide, please. If you have left atrial appendage closure, specifically talking about Watchman here, your freedom from bleeding event is greater than 72% in the 6 months. Next slide, please. and overall a Watchman arm lead to decreased mortality. Like I said this thing before, I just like to take this thing as a grain of salt because with a grain of salt because of the fact that decrease in mortality is primarily driven by overall reduction of hemorrhagic bleeding, especially in the brain. And I'm not going to say that it has a direct drug effect in reducing the mortality, but overall benefit that you get from decreasing hemorrhage, primarily the brain bleeding, is a leading cause behind the decreased mortality. Next slide, please. There are several trials have been done for the Watchman. The most important thing that I get out of this slide is that what is a procedure safety profile? And the current generation that we are in, the safety profile that we started back in 2002 was close to 10% having complications of any nature during the procedure. Now it is close to 2.8, or the newer data, which I'm going to share with you in the end, is actually close to 1% or even less than that. Next slide, please. Next slide, I think this is just to reiterate what I said before. The newer generation of Watchman is called Watchman Flex device, which is actually approved very recently, and it has a much better safety data. Next slide, please. It has shown this is a Pinnacle Flex IDE trial, which is primarily taking primarily taking patients who are run-in-the-mill kind of non-valvular atrial fibrillation, and it is a multi-center trial comparing any patients who are a candidate of Watchman as well as a candidate of blood thinner, and trying to compare the non-inferiority for this device versus blood thinner and preventing atrial fibrillation related stroke. Next slide, please. And these are, like baseline features and demographics of the population that we have, which is pretty much, general kind of population that you see every day in your clinic. Next slide, please. And it has shown consistent benefit, like in the previous trials that have been done in the Watchman. And basically, the most important thing that you can get out of this slide is that the success rate of implanting Watchman is close to 99%. Next slide, please. And safety endpoints are remarkable. If you look at the slide on the right, the goal was set about like 97% to reach the safety endpoint, including anatomical efficacy endpoint. And looking at all these endpoints, the success rate is actually 100%, which is remarkable for a new device that is coming out. And the safety aspect of this device is really, really good compared to the older generation of Watchman. Next slide, please. The overall safety events, the side effects or the complication during the procedure is actually 0.5%, which is far lower than the risk of stroke as well as risk of bleeding compared to HAS-BLAD score that patient are enrolled in. Next slide, please. I think I discussed that already. This is the freedom from oral anticoagulation discontinuation at 45 days is close to 96.2%. And this is the reiteration of the data. Next slide, please. That at this present time, we have multiple trials, including in 2020, this trial has already randomized Watchman Flex with a direct oral anticoagulant, and including in patients who are lower risk of stroke. So this is the new territory that we are going in compared to what we have previously been evaluated, which is high risk of stroke. Next slide, please. The new ways are coming up to basically deploy the Watchman device. This is when I used to be in Ohio, we have developed a technique which is called CT fusion imaging. Next slide, please. We are looking at the 3D rendition model of a left atrial appendage and trying to compute in the computers to assess the size, size needs to be determined, especially without anesthesia. Next slide, please. Here, most of the patients that we have done before, they basically obviously require anesthesia, they require TE. This is the model that we have created where left atrial appendage by the computer is on the fluoro or the X-ray machine. And we basically deploy the device, if you see in the right territory where the 3D model rendition is actually was available. And this creates future ideas that this procedure can be done without general anesthesia. Next slide, please. Yep, this is pretty much the same. If you see in the right side, this whole watchman is actually deployed inside where we modeled it. Next slide, please. This is a CT method of evaluating watchman shape and sizes, and you can evaluate not only based on transesophageal echocardiogram, but also based on the CAT scan. Next slide, please. I will go to the next slide. Next slide. Now I'm going to change the topic and change the focus of stroke to a different category of stroke. Obviously, I cannot see the participant here, but I'm assuming most of the participants here are actually from the healthcare field. I will tell you there is a category which is called cryptogenic stroke. Cryptogenic stroke, in easiest way of definition, cryptogenic stroke is a category of stroke where you do not have other causes of stroke being able to be diagnosed. Like, for example, the most common cause of the stroke at this present time in the United States is actually atrial fibrillation. So cryptogenic stroke is a kind of a stroke which is not atrial fibrillation, which is not carotid artery stenosis, which is not something other than run-in-the-mill kind of a stroke that we usually see. And those strokes are often accompanied with PFO. PFO means patent foramen ovale, and patent foramen ovale in a layman terms mean hole inside the heart. Next slide, please. So just to tell everyone that this is not something new. This was actually being discussed at the time, greater than 2,000 years ago, when the stroke was defined as sudden onset of paralysis by Hippocrates and calling it as black bile. So this is not something new. This has been in some form of documented evidence going as far as back as 2,000 years. Next slide, please. And if you, and I will tell you that I was quite amazed by the drawing of Leonardo da Vinci, that how he actually described about a patent foramen ovale in his heart diagram in his manuscripts. So the idea of a PFO is not new. It has been discussed centuries ago, and we are actually still learning that how it impacts our daily patient population. Next slide, please. Now, there was a German scientist, a German pathologist who actually documented the Werko's triad, and this was also linked to patent foramen ovale. I'm not sure how many of you are familiar with Werko's triad, but if you go forward, next slide, please. This is related to some kind of conduit which actually lead to paradoxical embolization of brain ischemia. Paradoxical embolization mean that heart is basically connected with the right side of the heart and the left side of the heart by separation of the walls, and we call it as interatrial septum and interventricular septums. But when there is a hole inside the heart, the right side of the heart or the venous system sometimes have a clot that is going from the venous system to the arterial system, and it can lead to stroke or embolization in any part of the body in an arterial system. And this was actually first defined by him. Next slide, please. And this is the kind of specimen that in the surgery that you can see. This is obviously the clot on the right side, and it is actually going through the patent foramen ovale and can cause a paradoxical embolism. Next slide, please, and a stroke. This is a transesophageal echocardiogram view. Obviously, many participants in this presentation may not be a cardiologist, but I will try to make it easy that this is a septation that is existing between the left side as well as the right side, and there is a thrombus which is transiting from the right side of the heart, which is the left of the screen, and the right side of the heart, which is the left side of the heart, which is the right of the screen, and causing stroke. Next slide, please. Next slide. This is a specimen that has been recovered from one of the patient, and the surgeon, I think, they were having whatever, good time to make these drawings, but they are basically suggesting that how the clot actually travels from the right side of the heart to the left side of the heart, which is a paradoxical embolism to the PFO. Next slide, please. Next slide. In utero, the PFO allows the blood to flow from the right atrium to the left, but uh, as there is a birth, this hole should be closed. But in 25% of the people, it stays open. And when I'm talking about 25% of the people, you can expect the magnitude of this PFO is that world population is now greater than 8 billion. So 25% of the world population has it. So it's very common. Next slide, please. This is a cartoon. If you can just click on that video, this is just to show that how the clot basically transfer from the right side of the heart to the left side of the heart and can cause stroke. Next slide, please. Next slide. This is a most common way of detecting the hole inside the heart. You must have heard patients getting transesophageal echocardiogram and bubble study. If you don't know even the echocardiogram, if you can play it one more time, these are agitated saline. That is a contrast that is visible on the transesophageal echocardiogram. The bubbles are crossing onto the left side. This means that there is a PFO and there are very increased risk of stroke. Next slide, please. This is a transesophageal echocardiogram showing the clot that is going through the PFO, and this patient had a stroke. Next slide, please. And this is a CT scan showing the stroke in this region. Now, there are multiple patients who have PFO, but the patients who are at increased risk of stroke with the PFO are the patients who have aneurysmal septum. Of course, there is a hole inside the heart, but the septum is very aneurysmal. If you can, I'm not sure if it's a video or not, but if you can try to play it, but you can see that, this septum is very aneurysmal. So the closure of the PFO is not a new phenomenon. The closure of the PFO can be done surgically, but can also be done percutaneously. Next time, the first time the PFO was actually closed was done in 1975 in Oxford Clinic. And this is the kind of a device that they use, which is very rudimentary right now. But the concept is still actually workable, that these are the two devices, two discs that stays on the left and the right side, and they sandwich the interrater septum in between for the hole to be sealed off and closed. Next slide, please. What at this present time we know is that PFO is very common, but we don't know that how frequent this causes stroke. We don't know that which patient we should actually close a hole that can cause a stroke and how we can prevent the stroke in the future. Next slide, please. And we can go through some data to basically tease out how we can say. I always, if you can play this slide, I always tell the patient that, I'm a big fan of, Shark Week on Discovery, but what I will tell you that you can actually swim with shark, but you don't know which shark is going to come and bite you. It's almost the same situation with the PFO. We all have a PFO, but we don't know exactly which PFO is going to cause a stroke. So, and maybe this analogy might stick with someone, but it definitely stuck with me, that it's almost like, diving in the ocean with the sharks, so you don't know which shark is going to come. Next slide, please. Cryptogenic stroke remains a challenge, as I stated that it's a cause of paradoxical embolism. Patients usually who are younger, they are more risk of stroke, and the cost of stroke is really exponential, and it's close to 94 billion with these kind of studies that have been mentioned down, especially in US and EU. Next slide, please. There are several meta-analyses which has shown that, if you close a PFO, there is a benefit. Obviously, we at this present time, we don't just rely on meta-analysis, we rely on randomized controlled trial. Next slide, please. The randomized controlled trial, I will just take you through the history of randomized controlled trial without belaboring you, but I will tell you one thing is that we have learned a lot of lessons from those randomized controlled trial, because initially how the research has developed, our trial design, our trial selections have not been really best to really accurately assess this problem. Next slide, please. The limitation for randomized controlled trial is that it is not a very common incidence like atrial fibrillation. Low event rate makes it very difficult to design the trial. and also the unselected patient, which patient you're going to select to really have to see an effect of a device or to see an effect of any kind of intervention is very difficult to tease out. Last but not the least, there is also a time frame that you can basically follow these patients, and the time frame that most of the studies that were initially designed, they were designed to follow for 2 or maybe for 5 years, but not longer than that. And I'm sure you guys are mostly familiar with these trials that have been done in medical literature. They're not more than 5 years. Next slide, please. Um, Next slide, please. The patients in PFO trial, it is very difficult also because of this fact that high risk of the patients who have multiple stroke, they don't want to be part of the trial. So they often actually lead to off-label use of the PFO devices, and it becomes extremely difficult to enroll such patients. Um, the other issue is with the initial closure devices that they were actually very thrombogenic, and we literally do not know that it's a thrombogenic causes of the device, that the metal that they were made of, and how much residual shunt they have. Those trials also led to some negative data, which we're going to cover next. Next slide, please. These are some of the trials. There are a lot of trials that have been done. Some are still recruiting, and they're very old trial. As I said to you, recruitment is extremely difficult, and they have used multiple devices as well. Next slide, please. Next slide. Next slide. Next slide. Next slide. Okay. This is the first trial. Next slide, please. The first trial is basically closure or medical therapy of cryptogenic stroke, which was actually the first closure one trial. It did not reveal any benefit of closing the PFO compared to medical therapy. Next slide, please. Closure one enrolled, as I said to you, there were a lot of selection biases. They selected all the kind of PFOs. They selected maybe some devices which we don't use it anymore. Next slide, please. The next trial was percutaneous closure of patent foramen-ovale cryptogenic embolism in 2013. Next slide, please. This basically was also a negative trial, but the trial was challenged by the fact they have lesser population, about 400 patients, and they did not follow it for a long term. And it shows that the PFO closure does not reduce the risk of subsequent event in the patient with cryptogenic embolism. Next slide, please. Next slide, please. The RESPECT trial was a very well-designed trial, and it actually showed that if you close the PFO in a pre-specified per protocol, you have lower risk of recurrent events, but as treated analysis, not as per intention to treat. Next slide, please. This is intention to treat analysis. Intention to treat analysis, it did not reach the statistical significance, which was 0.08. Per protocol, it was 0.03, and as treated, it was highly significant. And the reason for these kind of different outcomes was basically based on the fact that some of the patient transition from one group to another. That is probably, I think, the reason why this trial was negative. But this trial was definitely bigger than the previous trial. This is a follow-up of a shorter time period, and I'm going to show you a long time period follow-up afterward. Next slide, please. This is pretty much what we discussed about intention to treat principle. The device group definitely had lesser stroke, but it did not reach the statistical significance, which is 0.08. Next slide, please. If you are going by intention to treat principle, next slide, please. Next slide. Per protocol, there was definitely better reduction of stroke in the device group, which is 0.03, which has reached the statistical significance, the 63% reduction of stroke in favor of device. Next slide, please. As treated, it was even better, 72% reduction. Next slide, please. Next slide. Next slide. If you look at subpopulation benefit, the larger the shunt is, the better the stroke prevention is. And if you have atrial septal aneurysm, the better the stroke prevention is with the PFO closure. Next slide, device. Next slide, please. Looking at the RESPECT trial that we discussed just right now, has a longer follow-up. They followed these patients up to 10 years. This was presented in TCT in 2016. Next slide, please. And it shows that if you are intention to treat, the medical management has more stroke by the 10 years as compared to the PFO device, especially when you're following them on long terms. And the whole idea for PFO closure devices is that you are preventing a recurrent stroke on a long-term basis, not on short-term basis. Next slide, please. This is pretty much the same thing what I discussed about freedom from recurrent ischemic stroke, and especially talking about at age of 60. So this is what I would like to spend some time here, that why it is about the age of 60. The longer, the older the patient is, you have more other causes of stroke. The younger the patient is, the more you have chances that stroke could be cryptogenic. And there's a scoring method to basically predict whether the stroke is a cryptogenic or the score is not cryptogenic, and it's called ROPE score. I don't have the slides in this slide deck, but I would basically try to convey the message that if you have a patient who is older than 60, please try to think some other causes of stroke rather than cryptogenic stroke. They tend to have more stroke, which is like atrial fibrillation, which is like carotid artery disease, or some other kind of stroke. But the younger the patient is, the more chances the stroke could be cryptogenic. And think about a PFO. Next slide, please. This is a device which was approved. There are multiple devices which have been improved. This is in 2016 Amplatzer PFO device, which is a percutaneous closure device. Next slide, please. Next slide, please. This is another trial which basically simultaneously came out with the RESPECT trial in that same year, probably, or just following that year, from Europe, which is called PFO closure and go reduce clinical trial. Next slide, please. This trial uses a different kind of device, pretty much a similar design of the patient with the PFO and cryptogenic stroke, but this is a different device than the MPLAT, the device that we talked about. It was done in 63 sites and in 7 countries. Next slide, please. It is randomized to medical therapy with aspirin and Plavix versus the percutaneous device, and there is a very, very strong follow-up of neurology up to 60 months. Next slide, please. And MRI imaging was performed for the stroke. Freedom from recurrent stroke in 24 months was significant. And next slide, please. The study achieved the statistical significance in both the primary endpoints as well as the secondary endpoints. And the conclusion from the study is that in carefully selected patients with cryptogenic stroke, PFO closure with GO device significantly reduces the risk of recurrent stroke with the number needed to treat of 28 over 2 years, which is remarkably low as compared to the previous studies, which has shown number needed to treat in more than 50. Next slide, please. Next slide. This is a closed trial, which is a French study, which basically shows that antiplatelet therapy was found to be superior to antiplatelet therapy alone at reducing risk of recurrent stroke in patients with a PFO closure with absolute reduction of 4.9%. Next slide, please. Next slide, please. And oral anticoagulation agent did not offer any more benefit. Oh, I do have the slide of a ROPE score. So I think this is worth spending time. The ROPE score basically gives you more point if you don't have traditional risk factors. Like, for example, if a patient does not have hypertension, if a patient does not have diabetes, if a patient does not have any history of stroke prior or is not a smoker, and there is an imaging diagnosis of stroke, they are very highly likely to have a stroke because of cryptogenic nature. Next slide, please. As you go older, the ROPE score actually shows that cryptogenic stroke incidence is lesser and lesser. However, the cryptogenic stroke is not as common as atrial fibrillation, but whenever you are thinking about cryptogenic stroke, it's a diagnosis of exclusion. I always like this kind of a checklist in my mind that you should think about hypercoagulable disorders, you should think about atrial fibrillation, which is the most common cause of stroke, you should think about think about thrombus, tumors in the heart. You should think about atherosclerotic disease, arterial disease, and last but not the least, May-Turner syndrome. May-Turner syndrome is a venous disease of iliac vein compression. It is actually more common than you think it is. And this obviously can lead to stroke as well in the setting of PFO or without the PFO. Next slide, please. Conditions that are associated with PFO, it is not every time it can happen, but cryptogenic stroke, as I said to you, the magic number that you need to remember is 60 of age and less. The patient of cryptogenic stroke, often they have migraine with or without aura. They can lead to problem with decompression illness and high altitude pulmonary edema. Next slide, please. PFO migraine association is not new. I will just leave you with this thought that there are multiple studies that have been done for PFO and migraine. Those studies have mostly tend to be negative. At this present time, there is no indication of PFO closure with migraine unless and until with the stroke that I mentioned before. But patients who have PFO, they often tend to have migraine. Next slide, please. Next slide, please. In 2002, next slide, please. I would basically say that patients, there are a lot of patients who have cryptogenic stroke. There are a lot of patients who have PFO, but there are very few they actually need a treatment. Next slide, please. And next slide. There are very few that basically need the treatment. Next slide, please. I'm not sure if you guys are a football fan, but maybe you guys know this gentleman. And again, this is not a HIPAA privacy issue because it was published in People's Magazine, so I took it from there. Next slide, please. He was quarterback and football, and he had a long flight from Hawaii, and he had a stroke. Teddy Bruscher. Next slide, please. And he ended up having a PFO closure. Next slide, please. This is a cartooning diagram of the septal issues that is called atrial septal defect between the left atrium and the right atrium. I will try to just spend a small time here about atrial septal defect because they are often confused with the PFO, but they are not PFO. However, the problem with atrial septal defects are often similar to PFO. They can also have a stroke, but there is a separate indication of closure of atrial septal defect. Next slide, please. Those issues that atrial septal defect can lead to is they can lead to more blood flowing from the left atrium to the right atrium and cause swelling and the enlargement of the right side of the heart, whether it's a ventricle or the atrium. And these are the reason where you need to close them. They may result in paradoxical embolism as well, like a PFO, but again, they are a different category of disease, but they are often confused. That's why I just wanted to give a flavor here to the audience that what these atrial septal defect means. Next slide, please. Next slide. I will skip these slides so that I can give some time. Next slide. Next slide. Next slide. Next slide. I can give time to some questions. And summary, atrial fibrillation is at an epidemic level. Atrial fibrillation is the most common cause of stroke. All atrial fibrillation patients are not ideal or not a candidate of oral anticoagulation. We should think about non-pharmacological method of stroke prevention. PFOs are very common, patent foramen ovale, but not the most common cause of CV stroke. It's almost a diagnosis of exclusion. The most recent trial regarding cryptogenic stroke suggests a higher risk group, which is atrial septal aneurysm or large PFO, benefit from percutaneous closure. Where PFO closure indication exists for patients who have even previous MIs and peripheral embolization. Migraine with aura or without aura can happen with the TI and CAV and can be associated with the PFO, but most of the PFO patients do have migraine, but if they don't have a TIA or a stroke, they are not the reason to close PFO. Next slide. This is a video I would like to play, but the reason I would like to play is because how does stroke look and sound like? And I will just end my slides here and I would like you guys to listen to it. Thank you very much. Is there a volume there? Thank you very much.
Thank you, Dr. Sardar. That was very enlightening and eye-opening. I know a lot of us in this space do a lot of work in prevention and try to educate our patients on how to not, end up in your office, right? And so we're thankful that you're there if we need you. But also I know a lot of our work really is in trying to prevent us. But as that video did highlight, it can happen to somebody who looks young and healthy, and it can happen to anybody, as you said. So with that, does anybody have any specific questions for Dr. Sardar? He is a provider at Memorial Medical Center. And so if anybody needs his contact information or would like to reach out to him, I can help you with that. Reach out to me. But I'll give the audience just a couple seconds to see if they have questions. This is a quiet bunch today. But like I said, these presentations are recorded. They will be posted on our PHC website, and shared with everybody for anybody else that wants to rewatch. Thank you to all our presenters. Thank you to Dr. Sardar for taking the time out of your clinical day to talk with us today and explain all of this information to us. It was very helpful and very useful.
Thank you for inviting me. I appreciate it.
Thank you so much, everybody. You have a great rest of your afternoon. And thank you for joining us today for our 2022 PHC conference. Thank you.